Okay, welcome everybody. Sue Grinnell here with the Public Health Institute, and very excited to have a colleague, Gina Morgan, who's the Chief Operating Officer at HealthierHere, which is one of the 9 accountable communities of health in Washington State. So they are in King County, Washington, which is Seattle. Share her story about their work. It's pretty fascinating. So I'm going to turn it over to Gina.
Okay. And I was trying to remember how I share.
Yeah, if you go to share.
Okay. All right. Okay, can you guys see my screen?
Yep.
All right, so thank you, Sue. Sue and I go way back to time in Washington State when, Sue, I think you were at the Department of Health right when I got started with the ACH related work in Washington State. So I wanted to speak a little bit today about a few things. We have ACHs both in Washington State and in California, and there are some important differences. So I thought it might be interesting to you all to understand a little bit about some of the similarities and differences between our ACHs and learn a little bit about how we have been thinking about our work. There are definitely some similarities between I think the CACHI accelerator sites, but there's also some differences. And since Lisa and myself have been joining some of these CACHI webinars, there have been parts of the conversation that have been interesting because there are some interesting comparisons or contrasts. And I just wanted to share a little bit about what we are doing in Washington and specifically in King County. Because I think there's good learnings between us. So that's really my goal for today. And given the size of the group, I want to make this pretty fluid. So if folks want to interrupt me with questions, if there's things that I'm talking about or differences that you're wanting to clarify between Washington and California, feel free to stop me at any time if you have some questions to ask. So let me first talk a little bit about the Medicaid Transformation in Washington State through Accountable Communities of Health. I think it would be good, first of all, to explain what a Medicaid waiver is. And I think it might be a relevant history for you all to understand that in Washington State, before we had a Medicaid waiver, we actually had a state SIM grant, a State Innovation Models grant, that actually brought me on into the ACH fold back in 2015. So that is where I got started. And that grant essentially allowed various ACHs around Washington State to really just get started. And in 2017, our state applied for and received a Medicaid waiver. And so what this waiver is, it's an agreement between the federal government, the Center for Medicare and Medicaid Services, and the Washington State Healthcare Authority, which is the Medicaid agency in Washington State. And essentially what this is about, it's allowing our state to use Medicaid dollars in new and different ways to test approaches. And some of the requirements around it is it has to be revenue neutral to the federal government. It's a $1.5 billion investment. It's a 5-year program. And it has some requirements around it, which I'll go into. So some of the work that predated the waiver in Washington was Healthier Washington. And essentially this is a plan that our state developed that related to these goals in front of you, related to whole person integrated care. It related to transitioning from volume to value-based payment by 2020. And it also included increasing the patient health and experience of care, population health management. And these goals, the way the state set it up, were to be accomplished through the creation of accountable communities of health across Washington. And so you can see in this slide, essentially what we were asked to do. So a number of us came from pre-existing organizations that were in our regions, this idea that health is local. So we came out of local organizations. Some of us were actually birthed out of public health departments around our state. I think the important thing to note here is that there are 9 ACHs in Washington state, and we are divided up by county. Some of us are single county ACHs, like in King County and in Pierce County, and the other 7 ACHs in Washington include multiple counties. And we are the entities that are responsible for overseeing the Medicaid demonstration in our region through health-oriented projects. I think the other thing that's relevant for us is we are really seen in our region as the conveners of a multi-stakeholder tables to address health issues and health disparities in our region. And what I understand with California that's different is you all picked your geographic regions, and I think you had between 100 and 200,000 people in them. I think you also, so you picked your communities and you picked the chronic conditions that you were going to address.
Mm-hmm. Mm-hmm.
In our state and with our ACHs, we actually had a set portfolio of projects that we needed to choose from, and I'll go into that in a little bit later. So essentially what our role is in our region is we are here to help identify community needs and strategies to help design innovations and recruit partners to participate with us. We have practice partners that are essentially the implementing organizations for the projects that we have chosen, and we are held to a very specific clinically oriented health measures, and that we have to accomplish certain kinds of performance. So we have to do reporting. We have measures that are being gathered on each of our regions regarding our ability to move these measures, and we essentially earn incentive dollars as a result of moving those measures. This is not a grants program. It is a pay-for-performance contract. So in light of that, what is HealthierHere in King County? We came out of the health department and King County government. We started as an initiative there, and we've been in existence for about 2 years as a new nonprofit organization dedicated to the health and well-being of people in King County through innovative cross-sector collaborations. We have a 26-member multi-stakeholder board, a professional staff of about 16, and our initial funding, we see really the waiver as a source. It's our only source of funding right now, but it is essentially allowing us to do, I think, broader work in our region that obviously we need to perform with the Medicaid waiver, but we have a larger vision for our region, which I'll go into. In terms of the multi-stakeholder board, the requirement from the state was that we have at least 50% non-clinical organizations involved with our board. And you can see here on the right hand, this is the various sectors that are represented in our board. This has not been prescribed to us by the state. This is what we have adopted for our region. So let me just stop there and see if there's any questions.
Gina, I thought when this all started, right, I'm just recalling that there was a prescription, like you had to have a plan, you had to have just different, and so has that changed in terms?
Oh, I see what you're saying. Yeah, there definitely, so I don't mean to imply that there were no other requirements from the state. What I'm trying to say is that the composition of our board was prescribed up to the extent that 50% needed to be non-clinically oriented organizations and sectors. We had a lot of other requirements. For example, we had to go through, as ACHs, we had to go through a whole registration and certification process. So part of it was for our 9 regions. We were 9 regions. The entity that was going to be the ACH for our region was not predetermined. We actually had to apply for that. be accepted as the ACH for our region. And then we had to go through a certification process with various requirements regarding multi-sector board, executive director, and various other kind of organizational governance and infrastructure capacities. Part of the reason for that was, and I have a slide that goes into more detail here, because the state was setting us up to be the pass-through entity for Medicaid waiver dollars, they needed to be sure that we were well-governed, fiscally sound, stable organizations that had infrastructure that could handle the potential to pass millions of dollars through our ACH out to our community and our community partners. So let me go a little bit more into details around HealthierHere as a new nonprofit in King County. So this is the ACH work in King County was predated by a number of years of work around health and human services transformation. So when the waiver came around and the ACH came to King County, this fit in very nicely with a recognition in our region that there were, even though you look at the averages around health and health disparities in health in King County, we look pretty good. But because of some of the work that the public health department was doing around looking at zip codes, for example, identifying that there are some large and growing disparities in King County. For example, there's approximately 5 years of age difference from people coming from high poverty areas, people enjoying on average 11 more years of healthier life, depending on what zip code you're born into. And we're also a very populous county. We have, we're about 2.2 million people. About 23% of Medicaid recipients in the state of Washington reside in King County. And approximately 21% of the residents of King County are covered under Medicaid. That's about 425,000 people are covered under Medicaid. About 58% of those are adults and about 42% of them are children. So, clearly we have some challenges in King County, and I think really the work that was allowed to happen under the ACH was predated by some work that was already going on in King County before the advent of the ACHs and the Medicaid waiver. So essentially this slide is really sort of talking about some of our challenges. Is in many respects we are resource rich. King County is also the county where Seattle, city of Seattle is located, most populous city in the state. We are resource rich, but we are not well connected, and it's really challenging for an individual to navigate the various systems in our region. So our vision is really a connected system of whole person care, such that no matter where a person enters, they can receive the appropriate care and the community supports they need to live a healthier life. And then overall, that the system is more cost effective and sustainable. So for us, what long-term success looks like, and these are some qualities that have been figured out, decided on by our governing board. And that is, I think that the question that we posed to our board several years ago was, here we had this opportunity for the Medicaid waiver to make a difference in our community, and these dollars are time limited. What does success look like? What will we have accomplished or put in motion through this waiver in our region? And that's where you see meaningful mechanisms for community and consumer voice. You see care teams that are representative and culturally competent and respectful of individuals and the community. We see interconnected computer systems that are allowing our community and clinical providers to bridge their connectivity and provide a more integrated care experience for individuals. And then we also have these payment models that can compensate providers for helping to keep people healthy, including community-based organizations. So this is a vision of long-term success for what the Medicaid waiver can help us accomplish in our region. So let's talk a little bit about Medicaid innovation, more broadly speaking, and this is essentially the role that we see ourselves playing in King County is a bridger, combining the Healthier Washington vision of improved outcomes at lower costs, and in helping to improve the care of individuals in King County to live healthier, more productive lives. And we do this by supporting clinical providers as well as community-based organizations to provide better integrated whole person care. And the model that we've adopted is this model of collaboration and innovation where we are trying to help connect organizations that have not traditionally worked together before. And we are facilitating partnerships across different kinds of providers, as well as government agencies and safety net services, testing innovative approaches and collaborations for the benefit of community and consumers in our region. And we are intending to use the earned Medicaid waiver dollars to make longer term investments in system-wide assets. So the waiver allows us to essentially test new approaches that are not traditionally reimbursable through Medicaid. And it allows us to test these protocols, and it also allows us to invest in organizations and practices to help them successfully provide integrated whole person care in a value-based payment environment. So we also have a role in helping to train up our providers and capacitate them for being able to operate in a value-based payments environment.
Gina, can I ask a question? Sorry to interrupt.
Yes.
Could you just say more about value-based payments? That's not a term I've heard before.
So let's see. Well, I'm not prepared to talk in detail about it, but there are that the state of Washington has developed that by 2020, I forget, 90% of our contracts would be value-based payment. And these are state goals. But given that we are entities that are contracted by the state of Washington, we have a role towards enabling and capacitating our providers to be able to function in that kind of environment. Obviously we know that it's a requirement that the state has imposed on our various regions across the state to transition to value-based payment contracts. And essentially we are enabling agents of that to be able to equip our providers in our communities to be able to function in that kind of environment. So we are doing things, for example, around, we know a lot of our health center partners are already making those transitions. There is a larger gap with some of our behavioral health providers in the region. So we have been doing some really targeted around value-based payment to enable them to figure out how to operate in that kind of environment. And although this work has not gotten started yet, we are also intending to do some knowledge transfer training for our community-based organizations, not to say that they need to operate in a value-based payment environment, but to the extent that they want to, and we're trying to encourage stronger partnership between community and clinical organizations for them to have a broader understanding of what value-based payment means and what it means to partner with clinical providers who have that requirement, I think is part of the training that we see ourselves being responsible for doing in our regions.
Mm-hmm. And Gina, I think, Erin, it's a great question, and I'm glad that you asked it. I think what's different in Washington than California is Washington has a set of metrics that they've agreed to, for better or for worse. Right? And under this system, when you achieve those metrics, right, which does have value, they're incentivized for that. In California, the ACHs have not agreed. There isn't any structure because philanthropy is funding it, not the state Medicaid agency, there isn't any set of metrics, right, that you could as Napa County, like work with partnership as a possibility, right, to agree to a set of metrics, and they might be able to incentivize. But I think that's another piece to this. I mean, and that's probably like a whole other web discussion, but I'm so glad you asked. I mean,
so just want to make sure that I'm tracking. It's a value-based payments it's a metric system that is measuring the quality or perhaps the efficacy of care versus the number of folks we served. Is that right?
Well, I'll go into the metrics in a moment so you can see about more about that. And that's probably, you can revisit that question.
Thank you, Gina. Thank you.
So these are what we call our innovation targets. And again, I think this is another distinction between Washington and California ACHs. I understand that you all had a defined portfolio of interventions in 5 focus areas. In Washington, when our Medicaid waiver was put together, we were given a choice of 8 different projects that we were able to choose from. We had 2 required projects, which was related to the opioid use disorder, as well as the bidirectional integration of physical and behavioral health. And then we were able to choose additional projects from that. What we chose in our region was care transitions, which involved supporting individuals that are transitioning from hospitals or psychiatric hospitals and jails back into the community, as well as dealing with chronic conditions. And I think for a region as large and as populous as ours, I think we recognize that all 8 projects had resonance and resonance in our region. It wasn't that we weren't choosing these other projects because they weren't important to us, but we went through a very deliberate sort of strategic process around evaluating where we thought we could have the best ability to move the metrics, the clinical oriented metrics that were a part of signing on to each of these 8 projects. And I'll show you that in just a moment. But essentially, the way that the waiver works is we are required, in order to earn our incentive dollars, to move these clinical oriented metrics. And that is what earns dollars into our region. Once the dollars are in our region, we actually can choose how to spend them. So that is where I think some flexibility comes in. But we made sort of a calculated sort of gamble around which metrics we thought we would have the best opportunity to move. So this is the social equity framework that we have put around our 4 projects. And we really think of it, more as a portfolio as opposed to individual projects that we are kind of singularly working on. So around our 4 projects, we also have looked at a focus on improving equity and reducing disparities. We're looking at addressing the social determinants of health and at community-based care coordination, because these are the things that for our board and our stakeholders and our community members has a lot of resonance around the need in our region. So we're trying to sort of leverage these projects with a larger frame around social equity to try to advance some broader goals in our region through the Medicaid waiver. So where we are today, our waiver was approved in 2017. Last year was about, so we did some design work, especially around, for instance, qualifying as an ACH, as I was talking about earlier. And then we did a lot of planning around our project portfolio, and that process I spoke about in terms of figuring out which projects we were going to submit to the state for. And then 2019 has been about implementation, and then we will move into scale and sustain in future years. So I wanted to talk a little bit about the money, because I think this is an important distinction between Washington and California. So as I was mentioning, this is a pay-for-performance contract. So the federal government, the funds flow from the federal government to the state healthcare authority or Medicaid agency, and there's a fiscal intermediary. we as, so the Healthcare Authority, what they do is they will be measuring our progress on various clinical measures over the course of the waiver. And depending on our ability to move those measures, not just our ACH, but overall as a state across the 9 ACHs, that will enable the state of Washington to earn these dollars from the federal government. And as our regions have success on those measures, we draw down those dollars into our region. And as I mentioned, once we draw those dollars down, we actually have a lot of flexibility in terms of how we choose to spend those dollars. And the other thing I think that's important here is, we have been operating over the past couple of years around pay for reporting. So in 2017 and 2018, 100% of our dollars earned came from pay for reporting. And then starting this year, 25% becomes related to pay for performance, those clinical oriented measures that I mentioned, and then a larger portion of our earned dollars come through the pay for performance. So, not to say that we won't be able to move all of our pay for performance measures, but it's possible that most of the dollars that we are going to draw into our region has already happened because of the first 2 years. We have budgeted and planned according to that. We have very, very cautious estimates in terms of what our ability to move those measures might be and how much additional dollars we might be able to draw into our region. So this next slide is really about those pay for performance clinical oriented measures that I mentioned. And what you'll see here in the brown is the 4 projects that we chose for our region. And you'll see as you look down that, that these are the measures, the clinical oriented measures that we need to move. And you'll see that there's also a fair amount of overlap amongst the projects that we chose and the measures that we have to move. And as I mentioned earlier, this was done with a fair amount of intentionality because, for instance, we knew we had to sign up for the bidirectional integration of care project, but the transitional care project, there's a lot of overlapping measures with that, as well as with the chronic disease and to some extent with the opioid use. So we really thought about this strategically in terms of sort of reinforcing measures that we could work on, 1 or 2 or 3 or 4 project areas and be able to move multiple measures that affect that one project. That makes sense. What this chart also shows is how these pay for performance measures also intersect with some other, for instance, managed care organization contracts, with CMS, with PED contracts in our state. So the point of this, including that, is just to show the fact that there's synergy across payers in our state. So there's 17 combined overlapping measures that we are all collectively moving. And we have that awareness around our projects and the measures that we have to move, recognizing that we're not the only ones who are trying to move these measures in our state and in our region.
Gina, that's so interesting. Can you go back to that? So I'm wondering, I don't know what that's done to relationships or systems or anything like that. I mean, I don't know.
How would I say? I mean, I think if anything, I would say especially with the managed care organizations who are very involved with our work in our committees and our governing board, I think we have been pretty much from the start, we've been working with managed care organizations and looking for alignment and synergies, and recognizing that that we can support each other in some ways in terms of the measures that we are accountable for. So I think that's actually one thing that has helped bring and keep the MCOs at our tables, and helped make us relevant to them in some respects. So I think one thing that has helped in terms of the work that we're trying to do in our communities.
Mhm.
So this slide is really trying to show, that there's an investment strategy, and this is what we have designed for our ACH. I think other ACHs will look a little bit different. But we have thought about our investment strategy from the perspective of system level investments that we can make. We talk about raising all boats. So we know that certain providers in our region have greater capacity, for example, at value-based payments and population health management and addressing the social determinants, for example, than others. So we've thought about how our investments can help invest in the system and raise all boats. We've also thought about this in terms of the investments that we can make in our region around individual organizations, both traditional Medicaid organizations as well as community-based organizations and tribes. So those kinds of investments, as I had mentioned earlier, some of the investments we've made might be related to, for instance, practice transformation, might be related to supporting value-based payments, understanding and technical assistance, especially for behavioral health organizations that have less experience with that. So there's different ways in which we have thought about using our dollars to support both system level investments as well as investments in individual organizations. And in terms of the role that we see, obviously the investing role is an important piece to the work that we are doing, but we do a lot of convening. Some of the dollars are essentially being used to bring people together so that we can address region-wide issues regarding, for example, doing some shared care planning work, working on social determinants of health screening, data governance. And so we have started work within our partners around that convening function. The investing function, as I mentioned, the training and technical assistance that we're providing to individual organizations, being able to support non-licensed direct service staffing. We are initiating some work regarding clinical information exchange and community information exchange, as well as optimizing pre-manage, which is a software that allows access for clinics and behavioral health providers to knowing when their clients or patients have been admitted into the ER. There's also work that we see around policy, so helping to remove barriers for partners in our region at the local and state level. And then finally, sustainability. And I think one of the strong values of our organization is around the investments that we make not being just short-term, temporary 3 to 5 year investments that when the waiver dollars go away, the initiative falls apart. We are really thinking about the investments we make in terms of how do we work with managed care organizations and providers and the healthcare authority to support longer term sustainability of our efforts, so that these essentially leveraging these Medicaid waiver dollars to longer term investments in our community. And then I would just go on more specifically to talk about the various investment categories that we have decided on actually just earlier this year around, as I mentioned, that strengthening the system through these foundational system infrastructure development and capacities, the convening work that I mentioned around bringing our clinical and community partners together to develop these blueprints around integrated care, shared care planning, community information exchange. And then finally, this last category is catalyzing and testing innovations in our region. We have established a shorter term, what we call innovation fund, to fund some quick tests of innovation, where we can bring clinical and community providers together around some ideas that they might have to test innovations that could affect our clinical measures or specific populations that experience the most disparities in King County. Okay, I'm going to transition, unless there are further questions, to some of our work around community engagement. So
Gina, how much money do you have in the innovation pot?
Innovation fund is, let's see, $2.5 million per year for the next 3 years. So have thought about funding approximately 10 innovations per year to the tune of $250,000.
Mm-hmm. And so you've not started that yet?
We have not given out any dollars yet, but we have been working with our community providers to develop the concepts around those innovations. And we're getting ready to do sort of an application process for folks to sort of meet certain requirements we put together around those and to start implementing those innovation projects this fall, hopefully.
It's a nice chunk of change.
Yeah. So let me go into some of our work in community engagement, which as you could see from my previous slides around our social equity frame and our longer term goals for the region around community member and consumers in our region being sort of activated and involved in the type of care that they receive. The work that we've done around community engagement, it's kind of multi-tiered. So I want to talk about at least 3 different tiers in which we're thinking about the work. First of all, I think it's important to recognize that, since inception, we have had community voice at our governing board table. And this was by design. It was by design. Currently 1/3 of our board is community, consumer, tribes, and community-based organizations. And I think we were very aware of the fact that when you engage consumers and community members, you can have, oftentimes there's you bring 1 or 2 community members onto your board and you feel like you're covered, but 1 or 2 community members cannot cover the voices of all the different kinds of diverse needs in a place like King County. So we really looked to the community organizations that we brought on board to be part of larger coalitions or alliances in our region so that that they could sit at our table, but also bring back the work to these larger, broader coalitions and bring that feedback to our governing board table. We also established from inception a community and consumer voice committee. This is a formal committee of the board. These are open monthly meetings. Community members and Medicaid beneficiaries, as well as community-based organizations, are invited to essentially, they're kind of an accountability to our board. We come to them when we are, whatever board-related issues that we are dealing with always goes through our Community and Consumer Voice Committee to get that perspective into the decision-making and the thought process of our board. And then we also have involved community and consumers in the work of our committees. We have a transformation committee, which is kind of like a program committee. We have a performance measurement and data committee, a finance committee, as well as I mentioned, the community and consumer voice. But all of those committees, those formal committees of our board, have community organizations and consumers involved with them. So the next way in which we are working with community is, as I had mentioned, we work with both clinical providers and community-based organization providers. And we have been, again, a region as populous as King County we have over 500 community-based organizations in our region. And so part of the work over the past year has been getting the word out to various CBOs in our region around the work that we are embarking on, the fact that we want to support and capacitate them to help improve health in our region and work with our clinical providers. So we have been doing these sort of broader listening tours across our county. We listen and learn, we identify strategic priorities, and then we assess capacity to bring those community-based organizations into the fold of our formal practice partners. So in terms of the listening and learning piece, we initiated a community grants program last year where we asked the various community-based organizations in our region to apply for a small grant to essentially to implement a survey in their region to identify amongst their clients what some of the greatest needs and gaps are in terms of the health services that they receive in King County. So essentially what that enabled us to do is, through our community-based organizations, have a broader reach out directly to Medicaid beneficiaries and to community members who are experiencing health issues and health challenges, to bring those needs forward to our awareness. So that is what we did with our community grants program. And then we've also gone through a process of identifying the types of community-based partners in our region that might actually help us address the 4 project areas that we have chosen for our project portfolio, and identifying those organizations who provide services that touch on these project areas. We have invited these organizations to complete an assessment where we've identified the populations that they have served, cultural competency, etc., with trying to match what we understand and know about our regional health needs with the kinds of populations that these organizations serve, and bringing them into the fold, making decisions around bringing them into the fold of our practice partners, so that they can help work with our clinical providers to help serve the broader needs of individuals in King County. So this is, in essence, what we are in the midst of doing, is building this broader sort of connected system of clinical providers and community organizations. And Sue, as I was mentioning, it's been a busy week. We actually had last Friday, we had our first official launch of bringing 300 partners together with clinical and community organizations who are meeting each other for the first time, and kind of initiating this process of like matchmaking and networking and getting to know each other, so that as we embark on projects together, they will start having these connections to each other that can help facilitate having a broader community clinical connection for serving people in King County.
That's awesome. Congratulations.
Thank you. So as I mentioned, we had this community grants program. These organizations conducted interviews and focus groups with Medicaid beneficiaries to solicit consumer voice. There were about 22 organizations that received these grants last fall, and did these community surveys and focus groups late last year and into early this year. And then through that, we actually were able to survey over 900 individuals in 11 different languages. And this is just a representation of the organizations that we brought to our convening last Friday. A variety of clinical providers, community health centers, hospitals, as well as community-based organizations serving a very diverse population in King County. And essentially these last 2 slides are really just kind of hitting home this point around the fact that, really, if we have the goal of addressing health and health disparities in our region, it's really the people who are closest to the problem who can guide us in terms of finding solutions for health disparities and health inequities in King County. So, as the famous proverb from Nigeria says, we want to go far. And that is what we're attempting to do through our clinical and community partners, as well as connection to community members in King County. So with that, I will stop and see if there are any additional questions in terms of what I've shared today.
Thank you so much, Gina. So is there, for the folks that are on, do you have any questions or clarifications or?
Let me ask a question of you guys. Is this just so different from what you guys are doing in California that you just can't relate?
You know, Erin, I see Erin and Patty is on. I'm wondering, Larry, I know you were walking and listening, but, you know, I'd love to hear any thoughts or this great question. Folks.
Oh, go ahead.
No, go ahead, please, Erin.
I think, you know, all of the social determinants of health, the community engagement lens absolutely resonates with the work that we're doing here. I think the partnership between government and nonprofit and sort of the way that you're really using some of the methods, which maybe feel kind of prescriptive, that they're a good step in line with what you want to do, and also the freedom once the product with you, and that's new to me, and that's fabulous. Can you guys hear me?
So Erin, I'm having a hard time hearing you. I don't know if it's your audio or a speaker or a headset.
It might be, and I'm just going to type it.
In the chat. I think I heard her say the consumer engagement was fabulous and resonates. Not sure what the rest of it was, but yeah, Erin, if you could put it in the chat, that would be great. Patty, I don't know, I know you're muted, or you were muted. Any reflections?
Hi, can you hear me okay?
Yep.
Okay, my computer is acting really weird, so I wasn't sure. I was reflecting on that Jessica often uses this very same proverb, so I thought that was interesting to, you know, show how, yes, I absolutely agree. It takes time to build relationships, but that's how you get furthest. So I definitely don't think that you're all that different from here in California. In fact, we often sort of turn to your website to look at some of your resources. And I know HealthierHere Washington was one of the resources we looked at when we were thinking about building our partner network. So it was great to hear more and to learn more.
I do think, Gina, and maybe I'm wrong, but the orientation in what you're describing is much more clinically based than it is in terms of where I think in California, you know, where it's probably more community, kind of public health, population health, kind of community based. And I don't know that in all of the cases, right? Like I was at a meeting the other day in Lake County, and they had both of the hospital CEOs there and an FQHC, which I don't know that that shows up in all of the ACH side. So I think that's one thing that's, I think to me is very striking, you know, is just kind of orientation. And now you're kind of moving in to do this connection, at least like that seems. And I think the other thing that I talked about, right, is just the metrics. For me, that's a huge issue. You know, not having that. I think it you know, like what are we all working towards as a system across the state? I think it's good. Whether you agree with what the metrics are, the theory, right, that you all have metrics and that you're working towards it. And I think, you know, the other one, right, is just the amount of money, you know, that you have that's available to you to flow through all of the ACHs. And I think, again, that just speaks to the coordination at the state level, where, you know, they see the ACH as the vehicle for this coordination to occur, which is really in keeping with what this is about, right? Like it's, you know, this is this organization. So yeah, it looks like Erin, thanks Erin, says lots of what you're presenting, the community engagement piece, as well as the collaboration between CEOs and governments resonates. What I think is great and different from a lot of our funding is that once you have the dollars, you are free to do with what you want with them. That's awesome. So that's great. Yeah, I'm excited for you about the innovation money. Like,
Yeah.
that's awesome.
I thought I might mention this. I might mention this, Sue, because we had spoken about this earlier. Details in this, but we have the through the measures, and I want to talk about the measures in a moment, but through the measures, we have an up to amount budget over the 5 years of the waiver of $97 million.
Oh, wow.
But that's if we perform. And so of those 97 million, we have 75 million of those are what we call project fund incentives. So these are the dollars that we're using to make investments, the various investment areas that I mentioned in the system level and the individual organizations in our region. We have set aside 5 million for a wellness fund. It's not a lot of money to start a wellness fund. And I think we are, at this point, so part of the reason we did that is because we recognized while it's wonderful to have these measures that we have to perform against, I think there's been a lot of debate in terms of, how can you have, like, if the state is trying to accomplish larger goals, if you have these very clinically oriented measures, that's not how. And I think in Washington State, we had the common measure set that we developed statewide around these clinical measures. And so for the projects that the state put forward for our waiver, they connected them with these common measure set clinical measures. And so we had to sign up for them. I think there's been a lot of criticism around those measures because they are more output oriented, less outcome oriented, and they have nothing to do with the social determinants of health. So part of our desire to set up the wellness fund had to do with the fact that, we are going to have to make investments that help us move the clinical output measures. And we also want to make investments around social determinants in our region. And that is where we're seeing the potential for the wellness fund to be able to support some of that, after the waiver is over. So that's sort of how we've handled that. But I would also say that, I think we could have taken the approach around our 4 projects of focusing our efforts and the efforts of our providers around, all right, let us figure out how to move these clinical measures. And that's going to be our focus for our project incentive dollars. I think there's some debate as to whether, how effective that would be, especially because we don't have, live real-time data around, there's a data lag in terms of when the state lets us know where we performed on our clinical measures. So we don't really have, it's like driving, looking in the rear view mirror. Like, we can't really understand what impact we're making on our clinical oriented measures if we're looking in the rear view mirror to see how we did. So I've made some decisions around these system level investments that I've called them system level investments, because essentially it's like we're saying our region, in order to achieve integrated whole person care, we as a system need to work better and more effectively. And so we've made that decision to invest in that way, as opposed to very project focusing only on our clinical measures. So that innovation fund is how we are focusing on those clinical measures. But I would say our broader strategy and portfolio is around leveraging these dollars for goals and aims that are unique to our region and the social determinants and so forth.
This is Larry. The 97 million, is that for the state of Washington or for your region?
It's for our region.
Yeah, that's what I.
23% of the Medicaid population in our county.
And the dollars,
right?
Yeah. Are the dollars that you get, like, across the regions based on that percentage?
Yes, they're based on percentage of Medicaid beneficiaries.
Yeah. Okay.
And I would just say, for those of you who think that's a lot of money, which it is also, I would say, a huge responsibility, because I think we want to make a longer term difference in our community, and really figuring out how to invest that in these kind of longer term system transformational ways has been challenging. And also doing that through our stakeholders and our committees, sort of working as a region to try to identify, like, what do we need as a system to be able to provide better care to our residents, not what does my individual organization want to do and implement around this chronic disease project. It's a very different question we are posing to our partners, and it has taken a lot of discussion, challenging discussions, meetings, really calling people to a higher vision for what is possible in our region. And that, and because we are stewarding these dollars, it's its own unique challenge to figure out how to spend them in a way that's going to make a true difference.
Yeah. Gina, I had another question. Earlier you were talking about the composition of your board, and that the community members, right, are going back to maybe their respective groups. And
yes.
Maybe I kind of interpreted like almost like as a liaison. Is that is the responsibility of those people doing that, like going back to their organization, is that laid out in a charter, like your whatever it is your authorizing documents are, if it's bylaws or charter or MOU, whatever, like that kind of explicitly says, this is your role, right?
Yeah, it is explicitly laid out in our bylaws, and it actually is not just for community organizations and community members. It's actually broad, it's across the board. So for example, if you are, like, we have our hospital seats, we have 2 hospital seats, or actually maybe it's 3. Well, I guess it's 3. But those hospitals are connected to a coalition in King County called Hospitals for a Healthier King County. And their role actually is to speak to that coalition about what's going on with the King County, the ACH in King County. Same thing with, for example, our community health centers, or FQHCs. They have their own network of all of the FQHCs in King County. Their job is to keep their network of FQHCs in King County informed of the work of the ACH. So similarly with our community-based organizations, and for example, one of our community-based organization board members is also on it's called the Healthy King County Coalition. It's a network of community-based organizations all over King County that are focused on health. So they bring back word of the ACH to that network as well. Other one in King County actually extends down into Pierce County. It's called the Regional Equity Network. And these are organizations that originally came together around sort of transportation and transportation equity issues, but have kind of extended their mandate on just sort of getting community voice into a lot of the regional decisions that are being made. So their role is to bring what's going on at the ACH back to that regional equity network.
That's great. That's perfect. Well, we're just about, I think we are out of time now. So thank you. Amazing.
Yeah. Sue. Thanks, everyone.
Yeah. Thank you so much. Thanks for joining. Have a great weekend, everybody.
Thanks.
All right. Bye, everyone.